And
okay. Order. Good afternoon. This is Monday afternoon, and it is the House of Commons Health and Social Care Select Committee live from the Thatcher Room in Portcullis House in Westminster. And it is a special session today because we have the work of the Department of Health and Social Care, and that can only mean that we have Victoria Atkins MP, Right Honourable Victoria Atkins MP, who's Secretary of State for Health and Social Care. Nice to see you again,
Thank you.
Victoria. And we have Sir Chris Weld, who is the Permanent Secretary at said department. Lovely to see you both. Thanks very much for making the time. As you can see, we have cross-party committee of members all here wanting to ask an array of questions. And as is tradition, I'm going to kick off. Obviously, since we last saw you, we've had the spring budget. And very pleased to see that health was very much at the heart of the spring budget. Now, the Chancellor committed the NHS to 1.9% average productivity growth from 25-26 through to 29-30. And, that obviously picks up on the productivity assumptions in the long-term workforce plan, which were, I think, sort of between 1.5 and 2% were the assumptions that were in there. So it's on the almost top end of that at 1.9. I just wanted to get your reactions first off to that, Secretary of State. Is that realistic? I'm guessing you're going to say it is. But more importantly, how is your department going to deliver it working with NHS England and this massive system that obviously you sit at the top of?
Yeah, well, thank you very much indeed, Mr. Ryan. It's a pleasure to be before the committee again. And first of all, can I just emphasise what a significant budget this was for health, because not only were we able to protect real terms spending, but this, as you've rightly identified, this enormous injection of not just money, but also, I think, an injection of faith into the system as a whole, because I think we all recognise, last year we celebrated the 75th anniversary of the NHS. It has to move with the times. In my speech to the Nuffield Trust, I talked about the NHS having an M&S moment, and to me, tech, AI and life sciences are absolutely how we're going to achieve that. Now, in terms of productivity, if we look at the 10 years between 2010 and 2020 before the pandemic, the NHS was achieving roughly 1% in productivity gains. With the pandemic, for understandable reasons, that changed, and we have now tried to come out post-pandemic to improve productivity, but we have not got to where we would all like to get to. And so when we look at this productivity plan, including the assessments for the future and the modelling, not only do we, does Treasury have confidence in those figures, but importantly, of course, so too does the Office of Budget Responsibility, and indeed the Chief Executive of NHS England herself, Amanda, who has absolutely committed to this the productivity gains, certainly in the final 2 years of the scorecard period. And what this means is, how do we explain this in ways that aren't filled with jargon? What it means is, if we're able to roll out basic tech up-to-date technology across our frontline workforce, we believe that will free up to 13 million hours of clinicians' time. If we're able to use some of the emerging technologies when it comes to scanners and so on with AI, that is not just going to help clinicians in terms of time saved and accuracy of results. It's also, of course, going to bring huge benefits for patients. And so we're absolutely committed and assured of this productivity figure. The next question you've quite rightly asked me is, how are we going to deliver this? And again, this, I think, requires not just, it cannot be business as usual. We've seen some great movements, I should say, in this space already. For example, the NHS app, and the fact that 3 out of 4 adults now have that on their phone. The fact that if you go to a hospital or a surgical hub such as Heatherwood Hospital in Surrey, you can see the future of having a paperless hospital and the impact that has on improving care for patients. But we also, I think, have to bring in external expertise to deal with some of these massive issues that we have in relation to technology and AI, because this is a medical revolution. I've used that phrase before. It's not just in the UK, it's around the world. And of course, we want to draw on the brightest and best brains that we have to help us deliver that. And what that will mean is that we will be delivering logistical and procurement programmes as we go into the 5-year scorecard period. But what we want to ensure, for me anyway, what I want to ensure is that we're really working with frontline staff at the very beginning, because we need them to help us understand what they need, just as has happened with the Federated Data platform already.
Just to pause there then, because the 3.4 billion breaks down, so the biggest chunk of it is updated, fragmented and outdated NHS IT systems. So you talked about, the use of artificial intelligence, for instance, in mammography. There's ending the paper records by March 26, which I know we're a bit behind on, but we've obviously had a major event in the health world and in the country. So the biggest chunk of it seems to be that. Can patients, I suppose, be reassured that when we talk about updating fragmented IT systems, you talk about procurement, this won't be lost in outsourcing to consultants and outsourcing to clever people who, will borrow your watch to tell you the time. We want it front end for patients, and I think that's what patients would say if they were sitting where I'm sitting right now.
Absolutely, and one of the advantages of, for example, AI, and this is more in the AI space than the sort of frontline, the basic technology pot. But we know from the use of AI elsewhere in the world that it has enormous potential to free up clinicians' time. So something like a quarter of a clinician, an appointment with a patient can be spent looking at a computer screen. Imagine how that would improve patient care if, instead of having to look at a computer screen, the clinician is able to work one-to-one with the patient, and then voice-activated AI draws up the notes for them to check at the end of the consultation. All of this, it goes without saying, has to be done with a relationship of trust with patients. And so, please, in our enthusiasm, my natural enthusiasm for this, I'm absolutely clear that we have to bring patients with us. It has to be done with trust. It has to be done with patients' consent and informed consent. Absolutely right. But we also must seize some of these opportunities that we see coming towards us very quickly, actually, with the development of tech over the coming years.
Well, I suppose one consequence of that is, we did a big piece of work shortly after I took over as chair. We published around digital transformation of the NHS, and one of the things that was raised with us, and we produced in that report, and is raised with us in the pharmacy inquiry that we're doing at the moment, is this interoperability between the tech in secondary care and in primary care, of which I include pharmacy in that. And we've heard really good reports about Pharmacy First, really positive reports in the pharmacy press about the launch that has made, and we'll be talking to your Minister Leadsom about that tomorrow specifically. But does this tech revolution get into the weeds of that interoperability between the different sections of healthcare, so secondary and primary?
It will do, and what is more, it's already happening in parts of the NHS. So I referred to Heatherwood Hospital Surgical Hub in my earlier answer. They have a really good working relationship between primary and secondary care, so that the data is able to be shared, again, with everybody's trust, with assurances about data confidentiality and security and so on, but able to be shared so that when the patient comes in for their assessment at Heatherwood, they're not having to ask the same questions that perhaps their GP has already had to ask them, or the GP has the data already on file. And so this relationship of trust has to work, but it also, I would like us to get to a place where that sort of data is being shared between different layers of care, so that we get the best results for patients. I don't know if the poem sector...
Yeah, I'll just add
could I bring you in here, poem sec, then, on give you an early touch of the ball, as it were. The Chancellor said, didn't he, in his statement, that there are parts of the NHS that are woefully inefficient. And I just wonder, as you pick up the point from the Secretary of State, could you touch on what you understand he meant by that?
Well, I think everyone knows, including the staff of, particularly the staff of the NHS. And it's particularly in some of the areas the Secretary of State's already pointed out, and indeed you have, around just getting the basics right. So if I was to say what is different between this plan and the various IT plans we've seen in the NHS before, with I think it's fair to say varying degrees of success, This is highly pragmatic and it's highly people-driven. I thought you drew the right connection right at the beginning, that this flows directly out of the NHS workforce plan. So it starts with the workforce and what makes life easier than those. It is not a tech project. So if you look at what do NHS staff say get in the way, it's interoperability, as you've already picked up, but I say it's also outdated equipment, takes a long time to log in the morning. A lot of it is not the dramatic cutting edge stuff, it's the getting the basics right. And I think that's what will be different. The fact that that's where it starts, and this very pragmatic and also long-term approach that we've set out, that's what's going to make it hopefully different from some of the previous projects.
Thank you for that. And the Chancellor referred several times to an NHS productivity plan, which I'm presuming that a lot of work's been done on that in order to inform the assumptions he made in the speech and the stuff that he then pushed to the OBR and brought through into the Red Book itself. What is the NHS productivity plan, and how formed is it, and when will we and the public be able to see it?
Yeah, it's a thing developed by the NHS, on which the policies that the Chancellor set out was drawing on. I'm not quite sure about their plans for publication, but
you think there is a plan for publication? There's no reason why.
What I was about saying, the NHS is viewing this very much as a living thing that it works with the sector on. And as I say, I don't know what their plans for publication are, but we ought to get away from the sort of model of reform that goes, here's the published plan, right? This ought to be a much more iterative thing with the NHS working with its sector, as I say, on a very pragmatic basis on what are the things that are actually going to make a difference.
Okay. Well, colleagues may wish to follow up on that later. I'm just going to move on. Secretary of State, could I ask you about, we touched on primary care, and touch on, so Pharmacy First, as I said, it has had made quite a splash. I suspect there's probably still a lot of publicity work to do, but anecdotally as an MP and as chair of this committee, I hear lots and lots of stories of people going to the general practice and being pushed straight to the pharmacy and going there first. My wife did the other day with my son. So it does seem to have had a good start. One of the challenges of it is medicine shortages. If you spent any time in disguise in a pharmacy, the conversation that you would hear time and again is, I've come to redeem my prescription. Pharmacist, we don't have that item, it's out of stock. There is a similar item that I could prescribe you, but you have to go back to the GP to get that prescription reissued for that item. Because obviously pharmacists only have so many prescribing powers, and there are only certain items that they can actually prescribe. We did a pharmacy round table recently as part of our pharmacy inquiry. This came up again and again and again. So you can see how it's drawing people to Pharmacy First, but in many cases where they're getting prescriptions, it's pushing them back to general practice, which is kind of defeating the object of getting them away from general practice. So I just wanted to ask you, how big an issue on your desk is medicine shortages? Because I think a lot in the sector would want to hear that it's right at the top of your worry list.
So just to put some context into this, there are around 14,000 medicines licensed for supply in the UK, and the overwhelming majority of those are in good supply. Just to reassure people, we of course know that there have been instances recently, very high-profile examples, where for reasons, and it can be a range of reasons, everything from manufacturing difficulties through to the availability of raw materials, sudden spikes in demand, or issues related to the distribution of the product, a range of issues that can affect the supply of medicines to our high street pharmacists. The department has a very established process for those, for when that happens, and they work, first of all, with the pharmaceutical companies concerned. There will be occasions where, for example, a medicine may not be as readily available in a particular dosage, but it is agreed that other dosages can be administered in order to try to replicate the dosage that is missing. That may not, it doesn't work for every medicine. We don't pretend it does. There may be alternatives as well. Again, where that's appropriate, as you've said, that can be prescribed. And then there is also always a lot of background work going on to try and free up these supplies, either from elsewhere in the country or indeed elsewhere in the world. And I say that knowing, as I say, I'm very, very conscious of the difficulties that this causes for people living with these conditions, particularly those conditions where perhaps the medicine required is highly specialised, doesn't perhaps have the, if you like, the competition of supply that paracetamol would have, for example. So we do understand that, but there's, as I say, very established processes for the department to try to get to the bottom of this. We, in terms of, I think in your question you may have been suggesting, do we want pharmacists to look to be able to expand the services of pharmacists to be able to cover those alternative medicines? That is not, I'm very happy to hear thoughts and evidence on that. We have not made a decision on that, but I think we are all clear that we want to be able to.
There are serious shortage protocols in place, which Parliament has to agree, and our understanding is that there are more of those coming forward to allow more of those replacements to be made by pharmacists in store. Is that your understanding?
Well, we keep these protocols under close analysis. I have not received that advice, but I do.
This is. It's all a question of balance. It links very firmly, actually, to the first discussion we were having. Everyone working at the top of their licence, including pharmacists, is one of the absolute key drivers of productivity. In terms of pharmacists doing replacement prescription, which, as you say, we do allow in some circumstances. It is a very carefully balanced clinical judgment, because while you want the convenience of being able to do that for all the reasons that you say, it of course has to be safe. And there are circumstances, of course, where you have to know the whole history of the patient in the way that a GP does, to be able to conclude that medicine B will be as effective as medicine A.
And to go back to our first conversation, that can be achieved through interoperability and technology, of being able to fully see and interact with that record.
It can, but it also goes with the skill sets of the people concerned. So we can't give you a generic answer. No. It has to be a clinical decision, case by case.
You appreciate
you allow that. Now,
if the pharmacy sector was sitting here, they would say, well, we are the medicine experts. And actually, in many ways, they're probably they are more experts on the medicines than the general practitioners are.
Yes, but they're not more expert on the patient. And of course, when you're taking these judgments, you need to be able to do both of those things. So you're absolutely right that we have traditionally underused the skills of pharmacists, and we want pharmacists to be able to do more. That's the whole point of pharmacy first. But we, of course, have to balance that with safety considerations. So, as I say, we can't really give you a sort of pat answer of are there more or are there less. It's what's the right thing that balances those safety aspects with the kind of service that you're describing.
I suppose the other way, now, where the Secretary of State was answering as well, is that so it's about replacement where there is a replacement and where we're happy that safety is in place to allow that to happen, but it's really addressing the shortage at source, isn't it? Because the shortage at source, if that wasn't happening, then what the prescription that was written would be honoured in the first place, wouldn't it?
Exactly, and we have seen a rise in shortages, not a huge one compared to the 1,400 drugs that the Secretary of State said are licensed for use. Some of that is for geopolitical reasons. This is a world market and is affected by all the world affairs that we've seen. Some of it is for very good reason, that we are seeing more and more specialist drugs to treat conditions that we could never treat before, which is a wonderful thing, but it normally means a very complex supply chain, a very small number of suppliers, and therefore when you get the kind of things the Secretary of State was describing, there's no fallback, as it were. So the nature of the market is changing in a very positive way, but it does give us greater supply problems. Now, I think it's I think it's right to say that actually a combination of the work we did around Brexit and then the work we did around the pandemic means we have a far closer grip of the supply chain than we have ever had before as a department, and we have far more intervention powers, both with the industry itself and in terms of the things we can do to get medicines into the country in terms of shortages than we ever have before. That, nevertheless, doesn't make the whole problem go away. And exactly as you were suggesting in your question, what you need to do is get to the root of what is the problem in this particular thing. Is it a manufacturing problem? Is it a supply problem? Is it a distribution problem? Is it a cost problem? And then deal with the matter accordingly. So in terms of your first question, do we take this seriously? Yes, very seriously indeed. We're successful at mitigating the vast majority of problems that arise, and indeed most of the issues we're managing no one ever finds out about because we've found a way to mitigate it. That doesn't help with the individual cases that you describe, but we take it incredibly seriously when these things do happen.
Okay, right, we've got so many things that we've already covered, a plethora of subjects, but we're going to talk a bit about the MHRA now. James Morris.
Thank you, Chair. Yes, so Secretary of State, in your opening remarks, you talked about essentially a medical revolution that's happening across the world with AI, life sciences coming up with all kinds of new breakthroughs and drugs. Do you think the MHRA is fit to help us take advantage of this revolution?
Well, look, I think we know that there was a significant backlog arising out of the pandemic. I think they've made considerable progress in restoring performance of clinical trials throughout last summer, and I welcome the fact that those backlogs have been eliminated. I think the fact that we have looked at the international market and said, look, the MHRA is respected and we want to be able to help them approve medicines that have been approved by similarly respected regulators around the world. We want to help them do that as quickly as possible. I think that will be a very significant step forward.
In the Lord O'Shaughnessy, in his review back in 2023, he said that a major contributing factor to the underperformance of the MHRA had been a loss of strategic capacity and capability. Do you still think that's an issue in terms of resourcing, particularly in relation to emerging technologies like AI? Has the MHRA got the expertise to be able to regulate a world where people are bringing forward lots of new applications in artificial intelligence?
New tech, in fact, medtech. Yeah, absolutely. So look, I think that's a really interesting question. I think the MHRA itself acknowledges that it has got to identify new pathways with this. There is a programme of work going on in the department at the moment to try and ensure that that MHRA is finding ways of having having the capability to assess the emerging tech, but to do so in a way that we are content with its governance. And we know, I do not want innovations in medtech to be lost or in any way delayed because there is a regulatory issue with it. So I absolutely understand the committee's interest in this.
Do you think we're a bit parochial in relation to regulation, in the sense that this is a global market? There's regulators in other jurisdictions, like in the US, the EU. Do Do you think we could sort of short circuit things by learning from other countries? Don't we have a rather parochial sort of approach in this country? That we feel as though we need to sort of reinvent the wheel.
Well, in fairness, that was very much the thinking behind I think it was Spring Budget 23, whereby we were in the world of medicines saying, look, if a comparable regulator of similar international esteem and respect has approved a medicine, then we want to short circuit what the MHRA has to go through to enable that to happen.
Do you think that should apply to AI?
Well, so there's a difference between, I think, again, I mean, you're demonstrating, if I may say so, the complexity of this. That I think there's a difference between, say, devices such as the Freestyle Libre, which type 1 diabetics now use and have a huge benefit. I declare an interest, I'm wearing one at the moment. That sort of technology will have a huge impact, is already having a huge impact. When we look at the use of AI, that may take many forms, including, as we've already talked about this morning, sitting on clinicians' computers, but also in scanners. And so there is going to have to be a way of governing the regulation of all these different forms of tech. I think the pathways that we're working on, we will get there, but this is very cutting edge. This is very cutting edge around the world, in fairness. So we've got to find ways that we, again, bring the public with us and make sure we maintain their trust.
Yeah, I mean, that was the thing I was going to... I don't think you'll find a medical regulator in the world that thinks it's on top of what's going to happen with AI. And it's a very different concept of regulation. So you regulate, I will simplify appallingly, but you're regulating a drug, you're taking a yes-no decision on whether it's safe. AI, the whole point of it is it evolves as you use it. So what is it that you are regulating? The underlying system or its use at each point. I think the point you raise about the major regulators working together is absolutely vital, and the MHRA would say that if they were sitting here
and they're doing that.
And they're doing that. And of course, in a number of ways, as the Secretary of State said, they're one of the most respected regulators about how you regulate vaccines, and the fact that we got our vaccine regulation quicker than everyone else is recognised across the world. So there's a lot we don't want to lose. I think the things you're raising about the complications of, as it were, the new world we're going into, I think if the MHRA was sitting there, they would recognise exactly what you say in terms of they're going to have to be building their capabilities to deal with that sort of world.
And indeed, I've just reminded myself that during the AI Safety Summit in October last year, the MHRA announced the AI airlock to reflect the ambition for the UK to play a leadership role in the future regulation of AI alongside the FDA in the US. So we very much see the potential.
Can I just ask you a bit slightly techie question about or a nerdy question about the accounts? I think surprised to see that the Controller and the Auditor General issued a statement disclaimer on the UK HSA and their accounts they weren't prepared to sign them off.
Yeah, this was on one specific thing. We covered this a few weeks ago in detail with the Public Accounts Committee. So if you want a full description, you can look at the very exciting transcript. It was a disclaimer related to one issue around a spreadsheet that managed the vaccine program. Right. No money went missing and nothing went wrong. In the time available, UK HSA, however, could not reach the audit standard of that the National Audit Office wanted to see. So it was a very, very specific thing that didn't involve either a failure of the vaccine program or any public money going missing. Now, quite clearly, and this, if you look at the transcript, you will see this, UK HSA knows it needs to improve across its financial systems. There was also a statement from the CNAG that they had improved a lot of their underlying capabilities in this area, but they didn't get there on this one thing, and obviously that was a failure.
When you say capability, you mean forecasting or just
so it's the system that manages the deployment of vaccines. So it was actually around the Omicron period when we were deploying. And there was essentially a communication breakdown where the change of system that the UK HSA had implemented, they didn't register with the National Audit Office at the right time. That was a mistake, absolutely clear. As I say, it didn't result in any public harm. As I say, the most important thing was the vaccines got in the right arms at the right time. If UK HSA had a fault in this area, they prioritised the health protection bit of their remit rather than the public audit bit of their remit, which is, it's the right way round. Clearly, you want to do both, and that will be their challenge going forward.
Okay, thanks for that. And just switching again to another subject. In our session, I think before Christmas, Secretary of State, I asked you about the Mental Health Act. And I think Minister Caulfield produced a letter last week which talked about the fact that the government had responded to the recommendations of the Joint Committee. I just wondered whether there had been any progress on the legislative aspects of us improving the situation in acute psychiatric care where people are detained under the Mental Health Act.
Well, of course, this is something that we keep under very, very close review. In terms of the practical aspects, I wonder, would you indulge me by just perhaps setting out, because there are so many aspects to it, obviously.
So just breaking it down, I think in Minister Caulfield's letter, there'd been 2 reviews initiated around acute psychiatric settings, largely as a result of concerns that had emerged in relation to the treatment of people high acuity mental health in acute settings. As you'll know, there's pretty poor record of data sharing in that area. There is a pretty poor, we're talking some of the most inadequate NHS estates for people with the most acute mental health problems. And this is related to the Mental Health Act because the Mental Health Act reform implied a larger investment in the capital estate. So I'm just wondering, do you think we are treating our most acute mental health patients well, and what do we need to do to improve it?
Well, there are many aspects to that. So, for example, we clearly, those who are required to live in inpatient facilities must have safe care as well as respectful care as well as the right medical care, and this applies whether they are, whatever their age range, and the needs of, for example, children and young people in an inpatient setting will be different from perhaps adult patients or those who are having to be kept in a secure environment. And so what we are trying to do through the way that we're looking after people in inpatient care is to ensure, first of all, some of those high profile concerns, complaints that have been that have featured in the press, that they themselves are being scrutinised. So we have the HSIB investigation into inpatient facilities to ensure that those very, very serious allegations are being looked into, but also looking at the relationship between community care and inpatient care. The committee will know that I asked CQC recently to look into Nottinghamshire because of the horrific case that area has seen, but also I wanted to ensure that the wider community was receiving the attention and the reassurance that it rightly deserves, and people expect, but also looking at the provision of the highest security facility in Nottinghamshire, namely Rampton. There are ways in which, when that CQC report is published, I think there will be some very, very important learnings for mental health systems across the country, particularly that relationship between, as I say, community care and the next step of inpatient care when people need that help in a very, very intensive period in their life.
Okay, thank you very much, Joe.
That's great. Okay, right, from MHRA to NICE next. Paul Bristow.
Just a couple of other questions first, if I may, Chair. So Chris, with my colleagues' questions earlier, you were talking about the regulation of AI through the MHRA and how that might be a challenge with drugs or pharmaceutical problems. You've got a yes or a no. With AI, you quite rightly identified the challenges will be that it's iterative and that it relies a lot on user application. So very much like devices, which are obviously iterative, new devices come out all the time, and it depends on clinician skill and how they're implanted. So what lessons can we learn, do you think, from device regulation for the use of AI? And isn't it time that we had a regulatory system which was geared towards devices rather than just geared towards pharmaceutical products?
Well, I think were MHRA here, they would say that is exactly what they're working on. They point out exactly the difficulties. And in terms of the lessons, I think you've put the most important one in your question, which is getting the right link between the piece of equipment and the human, as it were. So when we look at where medical devices have gone wrong, and there have been some very difficult examples, it's very frequently been about what is the quality of the clinician using the device, as opposed to is the device itself intrinsically safe or not, which again is one of the big differences with pharmaceutical products. I mean, obviously I'm simplifying, but that is the key difference, and that is what the MHRA is working on. I think they would say they're not there yet, because that is an extremely difficult thing to do, and of course historically we have regulated the humans in one place and the medicines in another place, and we're really talking about how you bring those two things together. So it is an exceptionally difficult challenge. As I say, I think the MHRA would recognise that that's an area they need to get to.
I guess my point is that it's been a challenge for a while. I mean, what we have is a reimbursement system with NICE or a regulatory system with the MHRA, and I feel I must declare my interests here. I should have done that at the start, forgive me. So I point members to my register and the members' interests. But I think critics would suggest that we have a reimbursement system and a regulatory system that favours a pharmaceutical model rather than a medtech model. And I think the advance of AI will prove that even more so.
Yeah, I mean, I think there's some truth in that. Of course, the system was developed exactly as you say, largely to deal with traditional pharmaceutical products, and it needs to evolve as medicine evolves and as the technology evolves. That said, it's very important that we don't lose the huge benefits that we get from the system that we have. As I said before, the MHRA is highly internationally respected, as is NICE. We therefore take the view that those systems need to evolve, as opposed to we need something completely different, because as I say, we've got two institutions there which countries across the world do look to as being examples of good practice. I think your general point is right. You know, the development of medical technology, hugely important, hugely valuable and unadulterated good thing, but it creates quite a lot of challenges for our traditional ways of running these systems.
Forgive me, I kind of went slightly down a rabbit hole there, but anyway, Secretary of State, let's just talk
Quite an
about,
interesting rabbit hole, if I may say so. But
let's just talk about NICE, just sticking with the MHRA and NICE. I think you referred a couple of times in your comments to the international recognition procedure which the MHRA have established to ensure that we have, as you say, we can take lessons from other jurisdictions internationally. And that's good because it will lead to quicker licensing of medicines and devices. But it won't have the desired impact if we don't have similar systems in place with NICE, which of course look at reimbursement and evaluation there. What efforts are going to be put in place to ensure that NICE and MHRA have complementary mechanisms?
Well, of course, they have different roles in that NICE has to make very considered and often very difficult decisions as to whether or not a medicine can present value for money for the taxpayer, and this is incredibly difficult.
So if the MHRA says this is absolutely safe, this procedure or this device or this drug is absolutely safe, there's no point having that there if then NICE doesn't have a fast-track system to evaluate the cost-effectiveness. There's no point having a fast-track system for licensing if it's going to take another 2 years to...
Yeah, no. The way in which the two systems operate, I think that's a fair comment. But there will be occasions, and indeed we've had high-profile ones recently, where NICE have arrived at a conclusion on the basis of the discussions that they've had with the pharmaceutical company, which lead to it's a very, very difficult result if it is a refusal on the grounds of cost effectiveness for those patients and families who could potentially benefit from it. So I very much take your point about not duplicating effort. But we still, I think, have to give NICE that space to be able to conduct that their role in terms of cost effectiveness.
Well, can I just encourage you to ask the two bodies to work together, so their regulatory procedures, if you like, or evaluation procedures on the part of NICE are streamlined. We don't want NICE doing something over here and the MHRA doing something over here, because it's no point doing it over here if it's not. If you understand what I mean.
No, I see that.
So, but I just wanted to move on to the major conditions strategy. Are we going to see it in May, do we think?
Well, I am very excited about this strategy. The committee will understand that sadly PERDA gets in the way of big announcements, but I am very much working towards post-PERDA and over the summer. Okay. I want to launch it. I'm very excited about it.
And just another question. Do you think, could you ask... Every single person we talked to when we discussed cancer told us that we should have a cancer-specific strategy. Everyone working in the cancer arena, every clinician, every person in that cancer area said that it was a mistake to include cancer within the major condition strategy. Are they all wrong?
Look, there are a range of views on this. The reason that the government has gone for this strategic approach to the 6 major conditions is actually because we know now that 1 in 4 adults have at least 2 health conditions. We know from some of the discussion we've seen in the press in recent days and weeks as to the impact that those conditions can have on people's ability to take part in the workforce, but also, of course, the emotional toll that these very serious conditions can have on them and their loved ones. And when I listen to, for example, the Chief Medical Officer, what he and others talk about is that as we are living we're living longer, we are accumulating conditions that sadly come with older age. We want to expand the period of life that we are living in good health, but also recognising that as a patient, if you're living with, let's say, 2 or 3 major health conditions, actually the health system viewing your conditions individually it's not necessarily in your best interest as a patient. So the way that CMO puts it in a way that I couldn't hope to improve upon. He says we've got to treat the patient, the person, rather than the sets of conditions with which they're living.
Let me just give you an example, because Kidney Research UK are excellently placed in the wonderful city of Peterborough. They're a charity based in our city, and they've contacted me and said, look, I think you appeared on Laura Kuenssberg recently, and you talked about prevention as part of the strategy, and they pointed out that kidney disease, if they had early diagnosis and treatment with kidney disease, you would be able to identify diabetes much more quickly and improve outcomes for people with heart disease. Is that the sort of thing you're looking at with the strategy?
With the strategy itself, we are focusing on the 6 major conditions that we know have the greatest impact on the health of the nation as a whole. So cancers, cardiovascular disease, chronic respiratory disease, dementia, mental ill health, and musculoskeletal conditions. It should not in any way be interpreted that if a condition does not fall within those 6, that somehow government's attention is not focused on them. We're just trying, as I say, to have this strategic as opposed to what can happen at the moment, this siloed approach. We want to treat the patient, and I appreciate there's a range of views on this, but those who do so much work to not just raise awareness but also to help sufferers of cancer, for example. That work, all of our work to continue driving forward progress with cancer services, of course that will continue. It absolutely will. It's just that what we're trying to do is instill in our ways of thinking for the future that we have to, we cannot just see these conditions in isolation. And prevention is a critical part of that, because of course we know that if someone is living with obesity, they may well also suffer from cardiovascular disease, they may well suffer from mental ill health and musculoskeletal conditions, for example. I'm just using those as examples, not for a moment saying that everyone who does live with obesity has those conditions, but we're trying to break this down so that we have a strategic approach to the person, because prevention is how we're going to help with many of these issues.
That's the other point that the Chief Medical Officer would make, is common causes. So if we are trying, for example, to create a smoke-free generation, that hits several of our major conditions, as the Secretary of State says. If you're cracking down on obesity, you're doing that. So when it comes to the what do you actually do about these things, you're very frequently talking about the same causes. That said, and I think this conversation has brought it out, you can argue this both ways. We work very closely with the cancer charities, and we completely respect their views, but there are arguments that go the other way, both in terms of cause and, as the Secretary of State says, in terms of treating the whole person, that argue for that more broad approach.
It seems slightly strange that not a single person gave us that alternative view. But anyway, look, I fully accept the point you're making. Just on a positive note, I completely support the increase in physician associates. I think they're a good way of ensuring that clinicians operate at the top of their licence. But we have heard some worrying calls and trends to say that perhaps PA should not be involved in diagnosing particular conditions or prescribing, even though we have nurse-led prescribing that's existed for a long period of time. What are you doing to satisfy public concern and address public concern about the role of physician associates, considering that they are going to form a significant element of your workforce, or the NHS's workforce in the future?
So look, physician associates have worked in the NHS for more than 2 decades, and they already form an important part of clinical teams across the NHS. They look after thousands of patients every day, but they do so and should do so under the supervision of doctors. So we've always been very clear that the role of associates is to work with doctors, not to replace them, and we would expect healthcare organisations to have very robust governance processes in place to ensure that they're working to the right level of oversight and supervision. But we have very much heard the concerns expressed, which is why we are bringing in regulations to ensure that that physician associates are subject to the sorts of governance and regulations we would expect. And we're very pleased that this legislation will be in place by the end of this year. It's really important.
Thank you. Thanks, Paul. It's just following up on that. The House Lords Secondary Legislation Committee said that those regulations would provide the GMC with powers to amend the regulation process on physician associates without oversight by Parliament. Is that your understanding, and are there any risks to that? Because that's what the SLSC have said.
I'm going to take that away, if I may, Mr. Bryan. I have not been alerted to that, but that'll be thank you for that.
Anyway, okay, let's bring in Paulette Hamilton.
Right. Good afternoon, Secretary of State. I just want to follow on from where Paul's questioning was relating to cancer services and waiting times. I'm just going to call out a few figures that were given to us. The faster diagnosis standard was 70.9%. It's down from 74.2% in December 23, and the target should have been 75%. Another example that was given was the 62-day referral to treatment standard was 62.3%, was down from 65%, but the target should have been 85%. Now, following on from all of that, do you still believe that we will be able to focus on a cancer strategy plan when it is swallowed up in that major condition strategy?
Thank you for your question. I'm going to try, if I may, to add a little bit of context to what we're seeing with cancer diagnoses across the NHS at the moment. So what we do know is that demand has risen significantly since the pandemic. Just to put that in context, what it means is that the NHS saw more than 3 million cancer patients from February 2023 to January 24. That's an increase of 26%, or 612,000 people in the same period pre-pandemic. And so that increase, of course, has had an impact on services. But we are nonetheless, and please don't take me as being in any way complacent, just to add some reassurance, because I know that there'll be people listening to this who may already be living with a diagnosis or maybe awaiting a diagnosis, and it will be an incredibly worrying time for them and their loved ones. We know now that nearly 6 in 10 people are diagnosed at stages 1 and 2. That's really good news, because we know that the recovery outcomes are better, both in terms of survival rates, but also the quality of life afterwards are better the earlier we can catch it. So that is a step forward. Of course, we want to improve that even further. And we also know that nearly 9 out of 10 patients are treated within 31 days of a decision to treat. Again, very, very worrying time once they've had that decision to treat. Nearly 9 out of 10 patients are getting that treatment within a month or just over a month. And so what that has meant is that 1-year and 5-year survival rates have increased for most cancers. So, for example, with early breast cancer diagnoses, women are, I think, 66% less likely to die from the disease within the first 5 years than they were 2 decades ago. But of course there is more to do, and you've rightly identified those targets. I want those targets to remain, because actually I want ambition in the service. I want people to be striving to meet those and exceed those targets. And we are going to be able to achieve this through a number of ways. So, for example, the rollout of community diagnostic centres. Some 156 CDCs have been set up across England. And that helps with testing and scans and diagnoses, not just in relation to cancer, but obviously that's a major part of it. We know, for example, the most recent figures I've had are some 7 million tests and scans and so on in the last year. That's really significant. We know also that we need to ensure that we have the workforce in place to support and treat patients. So we have seen more doctors working in clinical oncology. We're seeing more radiology doctors, and that will lead to better outcomes for patients. But all of this has happened, to return to your question about the strategy, all of this focus, all of this has happened even before I've published the major condition strategy. You know, I absolutely understand why cancer is such a focus for all of us, both as, you know, constituency MPs, but also, frankly, as, you know, human beings, mums, dads, brothers and sisters.
I absolutely get what you're saying, but what we need to understand is you have literally made the argument for why I believe the cancer strategy should be set aside, because of the large increase in numbers, and things are being buried within this long-term condition strategy. I always get it wrong, but I need to not understand, because I think you've articulated that very well, but would you ever consider making an exception of some of these conditions because of the large increase in numbers?
Well, look, we haven't published it yet.
Oh.
Invite me back when we've published it and see what you think, because, as I say, it's a finely balanced judgment. We've wanted that. Our motivation is not because we, you know, there's some, I don't know, philosophical disagreement with having a separate cancer plan. It's because we genuinely are trying to have this strategic approach, this people-centred approach. But, you know, I know the committee will invite me back when the strategy is published, and you've quite rightly set me the challenge of ensuring that it has the focus within the strategy that you and others would like to see, and I hear that loud and clear and feel it myself.
My last question is, do you feel that, oh God, I've lost my train of thought today, I must apologise. Does the Secretary of State see any risks in the phased rollout of the federated platform, and what work has been done to ensure that pharmacy and dentistry are included in this? You've talked quite a bit to Steve about hospitals and other areas, but I'm on that little kick at the moment. What about these other areas that at the moment have been left out, and they've not really been mentioned at all in this £3.4 billion for IT that's been talked about?
That's a really interesting question. So in terms of the Federated Data platform, just to take a step back, this was a system that has been designed by clinicians for clinicians. And when I went to Chelsea and Westminster to see how it works for myself, one of the features that most struck me was the enthusiasm of clinicians in using this platform. It has, you know, huge benefits in terms of freeing up theatre time. It has helped them move, as one of them described it to me, you know, moving from endless Excel spreadsheets to having the information in one place where they can swap people in and out quickly. If, for example, somebody can't come in at short notice because of they've got a stomach bug or something, they can move people around. And that's how, you know, we need to be nimble and able to use our valuable theatre time as best we can. We are doing this in an iterative process because we appreciate this is a big change for the trusts involved, and so more than 40 trusts are in the process of transitioning from one of the pilot programs to the platform. But we have also very much heard the concerns about patient consent and patient trust, and so as part of this we have sitting alongside the FDP a separate, if you like, data confidentiality program, so that we maintain that trust, because it's critical that we bring patients and, by definition, their clinicians with us. In terms of how we roll this or similar systems out across the system. I think it's a very fair challenge. My ambition would be that we get to a stage where this data is shared between primary care, however that's defined, and secondary care. But again, it has to be done safely, and it has to be done with both clinicians' consent and patients' consent.
So just to round off, because we haven't got much time, the money that has been identified at the moment, none of it has really been identified for the pharmacy service or dentistry service to update or to include them in any of the IT systems that are coming on board.
So we haven't those two types of service we aren't looking at the moment, because as we've already discussed, although we haven't touched upon dentistry so much, but they are it's a different relationship between a general practitioner and, let's say, one of their patients who's perhaps going in for surgery, from, let's say, a very qualified, very experienced pharmacist and somebody popping in off the high street for one of the 7 basic conditions. So at the moment, we're not necessarily there, but that's because of the way that, if you like, the separate primary care systems are, the services they provide, that, in the future, let's take it a step at a time. I'm really keen on seeing what we can do to encourage GPs to become part of this. I think we've got to do it step by step, but it's an interesting challenge.
Yeah, but sorry, just to draw the distinction, I mean, you're asking about the Federated Data platform.
Yeah.
The wider 3.2 billion, the productivity plan is for the whole NHS.
Yeah.
As it were. The Federated Data platform is for acute only at the moment.
Only for that's all I wanted to know.
Yeah,
That's I mean,
I think it's worth pointing. I touched on this earlier. How shall I put it? Big bang solutions for the entire NHS at once in IT has gone quite badly, as I'm sure you all remember.
Understatement of the afternoon.
Well, as I said, I'll think carefully about how I put it. But so we're very keen that we do this step by step and do it right, both from the technical point of view and for the very important patient privacy and confidentiality issues that the Secretary of State remarked on.
So my only request to you would be, those sectors feel as if they're left behind, and more people will talk about that this afternoon. Please, in your future planning, ensure that they are highlighted in whatever you've got planned going forward. If you're staging it, just mention them, because they are being left behind.
Yeah, I think that's a very important message.
And
there's very good reasons for doing this carefully in a staged way, but I think your message is exactly right, if I might say so.
Right, thank you very much. Right, let's bring in Rachel Maskell now.
Thank you so much. Sadly, cancer has been back in the news over the weekend, but I want to really focus around breast cancer. First of all, on the 5th of March, you made a statement around 1,487 women who had not been called for their MRI scans. I wonder if you could update the committee what has happened since.
Yes, thank you very much indeed for raising that, because I know, I imagine we all have, constituents will have contacted colleagues about this. So just to recap, because again we're being very careful to ensure that the extent of this issue is fully understood, so that we're not worrying women, who have no reason to be concerned because they're not part of this group. There is a historic issue that women who received radiotherapy above the waist to treat Hodgkin lymphoma between 1962 and 2003 were not given annual checks as they should have been, because they're at higher risk of breast cancer. The NHS has written to the 1,487 women who are affected by this to inform them, and we expect all women affected to be offered a scan within the next 3 months. They are lined up, local services are lined up to ensure that happens, and what is more, NHS England has established a helpline for women who worry that they may be affected by this, and have also briefed GPs and relevant charities to provide advice, because of course they may be the first port of call for a lot of people, and by way of not comfort, but just to try to ensure that the women affected are working within the facts as we understand it, and we're not worrying people unnecessarily. I'm told that the vast majority of women in this group will already have been receiving screening on a 3-yearly basis, but of course we want to make sure they have their annual screens in line with clinical guidance, and alongside this we have asked NHS England to carry out a national audit so that can be reassured that people at high risk of cancer will be systematically referred to the right tests and treatment when we need them. The NHS has also, I think since I made the statement, written to another 110 women who received radiotherapy between 2003 and 2013 and therefore need to be invited for an MRI scan. So that's what we've done to try to help those that group of women who I think we'll all understand will be very worried if they've received a communication from NHS England along these lines.
Well, thank you for the update. Clearly, the women affected will be very concerned, and I would ask if those appointments can be expedited, that they would be. But cancer charities, breast cancer charities, have said that the administration has failed previously, and therefore with this will never happen again statements which we hear timelessly, how will you ensure that systems will be put in place that it will never happen again?
So that is exactly the question I asked NHS England, and we have NHS England, I should say, because of course they're operationally independent, has a specialist team that identifies women at high risk and ensures that they are properly referred. I think we've all understood the historic nature of this, and it is because of that audit.
If I may just broaden it out a little bit, that it may be in this situation or other similar situations that the administrative procedures do not fail those individuals within recall.
Yes, and so this is where the national audit is significant, because again, this has happened on the particular facts described, but of course other people who may have received other types of treatment will be wondering whether, one can understand they will want that reassurance, and so this is where the national audit is critical. I've made it clear to NHS England that in the event that any such issue is identified in the future, we have to first of all inform people as quickly as possible. We have to identify the group, contact them as quickly as possible. I have to be able to update the House because of our collective responsibilities as constituency MPs, but we have to ensure that, as I say, NHS England is conducting this audit to try to ensure that there are no other groups of people who may be similarly affected.
What we want to do is obviously avoid the situation where you have to make
Absolutely.
further announcements.
Yeah.
If
and if I may, I'm being really careful because I hope I've been able to furnish the committee with the facts I have before me, but I am also, as you understandably raise, I do not want to make statements or give categorical assurances and then a year hence or whenever have to come back to correct them. So this is where the national audit is so important, I think.
If a woman has then gone on to receive a diagnosis, will they be eligible to have compensation?
I have to confess at the moment our focus has been on trying to reach the women and to ensure that they're given those scans as quickly as possible. as I say, that's been our focus thus far. I just need to, for me, I want to make sure that those 1,487 women have got the reassurances they need, and then we can look to the consequences.
I just want to broaden that out slightly around breast screening programmes as well. Less than 2/3 of women attend breast screening sessions, which, as we all know, the earlier you diagnose breast cancer, the more treatable it is. It's an incredibly low success rate. It doesn't even meet government targets of 70%. And yet we know that if it was raised to 80%, we'd see another 3,758 diagnoses. Could you set out for the committee why the government has such low ambition for diagnostics around breast cancer, and how they will raise that, and if they'll consider raising it to at least 80% of women undergoing screening for breast cancer?
Yes, so look, I'm not unambitious on this. I have, as Health Secretary, prioritised women's health, and of course breast cancer forms part of that. There are including maternity services and the setting up of women's health hubs in every ICB area by the end of the year. I want to get the message out to women that please, if they get contacted, please, they should undergo the screening, and we know the very real benefits that early stage diagnosis can have for women. I mean, it remains sadly the most common cancer in England, with some 47,000 women or people being diagnosed every year. But we know that we have more women surviving this form of cancer than ever before. You may, I know not whether the committee noticed when I launched the second year of the Women's Health Strategy that I have also announced funding for investigations, research into lobular breast cancer, because that form of breast cancer forms some 15% of breast cancer diagnoses, but it is incredibly difficult to identify at the moment. Frankly, there hasn't been the levels of research into that form of breast cancer as there have been other breast cancers, and that's around the world, by the way. And so I want to bring that up to speed, because the impact of that diagnosis with the difficulties that women are having with the availability of diagnosis can have it has consequences for their well-being and for their health. But I mean, look, the more we can do to encourage women to get screened, the better. And I do think that women's health hubs will play a really important part of this, because we want these centres of expertise so that a woman can go in, have conversations with the clinician about her health, whether it be her periods, changes she may see in her breasts, and be able to have those conversations so that she gets the expert help that I think we would all love to see for the women we care about in our lives.
Thank you for that. I really do encourage more ambition. I hope to see that in the major condition strategy when that comes forward. I just want to turn to another subject about whistleblowers and NHS complaints.
I'm so sorry.
Around whistleblowers and NHS complaints. Yeah. There's a very high level of NHS complaints. I think NHS resolutions say the cost of harm in 22-23 was £6.6 billion, quite an extortionate amount of the NHS budget. And as a result of that, clearly we've got to see a reduction, 13,551 claims that year. So I'm just wondering, what focus are you placing at the moment on reducing the number of claims coming forward? That can be misdiagnosis, that in itself we see over £1 million spent on that. So what are we doing to reduce the number of claims? And then just in a short snippet, because I'm conscious of time, so I've got one last follow-up question.
Yeah, so patient safety has to be at the heart of everything that NHS England does, because people want and expect and deserve the very best of care, whether it be in the primary sector or the secondary sector. But with that has to come a non-defensive transparency within the system when mistakes happen. And I think we've seen over the last decade or so, we have seen some very, significant examples of where care has been, frankly, not good enough. People have been hurt or worse as a result of that. And we have tried to drive up standards to ensure that those sorts of events never happen. Now, we have in the arena of patient safety, my last count, there were some 15 or 16 either offices or organisations, cohorts of organisations that are responsible for patient safety. And it is absolutely right that that is the golden thread that runs throughout NHS care. But one of the ways that we will help ensure that good care is delivered is to support those clinicians and other members of staff when they feel that something needs to be raised. And so that's why, for example, I welcome the development of freedom to speak up guardians. I think that is a very, very important part for the workforce, but also, of course, the most recent announcement of Martha's Rule, enabling patients and families to have another opinion when they see their loved one deteriorate. That can be a very significant step forward.
Thank you for that response. Sadly, the number of complaints goes up, not down. And one of the things that we're particularly concerned about is whistleblowers themselves having the freedom to raise this. And I certainly want to put it on your agenda, not least the comments from Robert Francis saying the process is limited in its effectiveness. There needs to be some legislative changes. We've heard from Rob Berens about a cover-up culture within the health service. And the NHS staff survey says that 29% of staff don't feel safe raising concerns and indeed risk of psychological harm. So clearly the system is not fit for purpose at the moment. What are your intentions to ensure that it is robust and staff are protected if they are to raise concerns?
Well, from next month, it will be a contractual requirement for all providers of NHS-funded care to adopt the new patient safety incident response framework, and that is a key part of the NHS patient safety strategy from 2019. It is believed that this represents a significant shift in the way the NHS responds to patient safety incidents. But I also think there is, the fact that we have, for example, we have the wonderful Harriet Hughes as our patient safety champion. The work that she has done already in the short time that she has been in role, I think shows the focus that we have on patient safety. As I say, I also point to Martha's Rule because I do think that's a very significant step forward for members of the public when they have issues they want to raise. But this is about culture change and the way that there is something about how the NHS cares for us as patients, but also needs to care for its members of staff, and that includes supporting them when they are raising concerns about their workplaces and the impact that that has on patients. And so that culture change has to run through all of this work, because we need clinicians not just to be maintaining their own high standards, but also ensuring that their colleagues are doing so as well.
Okay, right, and finally we're going to talk. No session would be complete without talking dentistry. So we're going to talk that with Paul Blomfield.
Thanks very much, Chair. Secretary of State, you'll know we had a session last week with the Dentistry Minister, and there are just a few points on that I'd like to follow up on. She told us that the promise in the dental recovery plan of 2.5 million new appointments had, quote, a high likelihood of not being reliable. Now, do you think you were being entirely straightforward with the British public when you led the announcement of the recovery plan on that commitment and made it a minimum commitment?
Yes. And I don't know, Mr Blomfield, perhaps you haven't had a chance to see it, but Minister Leadsom has written to the committee today setting out the background and the methodology underpinning the modelling of the impact of our plan to recover and reform NHS dentistry. And indeed, I'm looking at page 2 of the letter. The appointments, the modelling of the appointments, in fact, comes to 2.76 zero appointments. So in other words, we under promised, because according to the modelling it in fact was 2.7 million appointments. Have you had sight of that?
It's worth saying for the record that at the time of this meeting starting, and as of my inbox at this moment, we have not received
Mr Bryan, I apologise for that.
Come, but
and as I said, I'm very happy to share my letter with you if you'd like to see it, because we took it very seriously with that question that you posed of Minister Leadsom, and so, as I say, the modelling in fact shows a higher figure than the figure I quoted.
Well, that's helpful. I mean, in the discussion we had last week, you will know that Minister Leadsom said, well, it's modelling and you know how unreliable modelling is. It could be higher, it could be lower, but the statement that you put out in launching the plan said it will create more than 2.5 million appointments, and that's what you're sticking by now.
Yes, this is the letter before the committee, and it sets out the modelling, so including it very helpfully delineates the different measures and the impact that is believed to have on, for example, the new patient premium, which switched on the 1st of March, as you will know. It sets out the modelling for the golden hellos, for the minimum UDA value of £28 and dental vans.
Well, we'll look forward to dissecting that in detail. On the patient premium payments that you just mentioned, I think I'm right in saying that they come out of practices' existing contract values?
So these are premiums that are paid to practices for taking on new patients. So the whole idea being they will have an existing contract, but the idea is if you take on new patients, we want to encourage that. We want more dentists to do NHS work. If they've got an existing NHS contract and are not using it to its full extent, then we will pay them to have new patients.
I understand it's not paying them to have new patients. What I'm trying to clarify is, does it come out of the existing contract value? Because I understood that it did. Or is it new money, additional money over and above the existing contract?
So the funding available for the plan is £200 million.
I'm going to come to that very specifically. On the patient premium payments, does it come out of the existing contract value, or is it an additional payment to those dentists for those new patients?
So we want, forgive me, the two figures are not separate. So of the £3 billion, the at least £3 billion we spend on dentistry. No, Mr. Blomfield, I'm not accepting the premise of your question. So of the £3 billion that we spend on community dentistry, we have £200 million that we have been able to use to fund the dentistry recovery plan. And within that, new patient premiums are a major part. You will look, when you see the letter, you'll see that it's responsible for up to 1.9 million appointments. We see that as a really good way of switching on
I think with respect to Secretary of State, you're putting two
I'm
issues
just
together.
not accepting the premise of your question. I'm allowed to do that. Okay, all right.
Very specifically, the question that I was asking was, does the patient premium payment come out of practice's existing contract value?
So it comes. So we have a contract with dentists to perform their contracts. We know that there is an underspend within the £3 billion, and that is the 200 million.
Individual practices. When dentists get that patient premium payment, does it come out of their individual existing contract value? Because the concern is that if it does, which is our understanding, that it will mean that although they're being paid to take on new patients, there will be fewer courses of treatment for existing patients. So it's an important question.
I have not seen that analysis. I'd be interested to know who produced that analysis. As I say, all I can go off is the modelling, which is that this is up to, in fact, higher than 2.5 million appointments.
Can I then ask you, just again, that same question? It only needs a yes/no answer. Does the patient premium payment come out of practice's existing contract value?
Forgive me, the point of this is that of the £3 billion contract, we have the £200 million that we are funding the plan through. So we are asking dentists to use the full extent of their contract. That's what we want to go, so that when we have dentists providing services, they are not just using, 20% of their contract, name a figure, they're going to the full extent. This is also, of course, with, as I say, the other measures that we are bringing in, including dental vans and so on, to try to reach those underserved areas.
You're keen to talk about the 200 million. Let me ask you a specific question on that then. When you introduced the plan, you assured the House it was funded with new and additional funding. Quote, you said in the Commons, there is 200 million on top of the 3 billion that we already spend on NHS dentistry in England. And you were pressed on the issue and you went on to say, quote, as I've said, this is additional money. I have prioritised dentistry across the board, but this is 200 million of additional money in addition to the 3 billion. Last week, Minister Letson said that wasn't the case. She said, quote, this is all coming out of the 3 billion. Who was right?
So I've corrected Hansard, Mr. Blomfield, and I gave the answer in good faith, but I've corrected Hansard to correct this point. The point is that this plan is fully funded, £200 million worth of funding. Very different. I'm bound to make a political point from Labour's ideas, but we have secured the funding for this, and we are trying to deal with the very real and immediate problems that we see across dentistry around the country, trying to get immediate term measures alongside the longer term work to reform the contract, which I understand dentists and indeed the public wish to see.
Minister Letson was right that it's not new money.
Well, I have, as I say, corrected the record. Yeah.
Thank you.
Okay, thanks very much. Just to say, we do have the letter. Members didn't see it. Paul Blomfield certainly didn't see it before he asked you his questions, because I don't want anyone thinking that he's not informed when he's asking his question, because quite the opposite is true. No. But members haven't seen it yet from it coming into the clerks. Can I just conclude, because I know we need to finish, but I know you'll want to discuss this Secretary of State. The Tobacco and Vaping Bill, which you published last week, first reading, gets its second reading in the House on the 16th of April, so the second day back after recess. It's a landmark piece of legislation, and credit to the Prime Minister and yourself for bringing it forward. Notably, it gives the Secretary of State, yourself, powers to regulate the display, packaging, flavour and other aspects of vaping products, but the bill itself doesn't make arrangements for that, so the regulations won't come into force until they're made through secondary legislation. And I just wonder if you could update us and parliamentary colleagues on that, because obviously people are being asked to vote at second reading on something which they don't have necessarily the full information for, because so that's the first part of the question. Secondly, it will follow very, very quickly, I presume, because otherwise we're going to be taking powers that we're not using, and there is a matter of urgency to this.
Well, this is, I think, the largest public health intervention we could make. It will help with the almost one hospital admission that is made every minute of every day in this country. It will help, we hope, prevent 1 in 4 of all cancer deaths. We know smoking causes that at the moment. So the long-term prospect for this intervention, I think, are very, very significant, both for the health service but also for the individual. In terms of the bill itself, there are, if you like, two parts to it. The first part is the smoke-free generation, whereby we are ensuring that nobody currently aged 15 or younger will be able to buy a cigarette legally in a shop. We know the reason behind that being that we know the majority of smokers take up smoking before the age of 17, 18, 19, and so we want to nip that. We want to help them never gain the habit, but we do also understand the concerns of mums and dads up and down the country that there has been a tripling of vaping amongst teenage users in the last 3 years. And so with both of these elements of the bill, this is not about affecting adult smokers who are already smoking. We are not going, we only want to support them to quit. We're not outlawing their ability to buy cigarettes. And so too with reusable vapes, we want to support adults to quit smoking. We are, however, getting rid of disposable vapes because we know that 69% of teenage users of vapes use disposable vapes. They're cheaper, they're covered in attractive colours and have wonderful flavours that apparently appeal to younger taste buds and so on. So with that, because that is more, if you like, more complicated, we want to make sure that we get the regulations right. And so with smoke-free generation, that is a matter for primary legislation, and we are adopting the powers for the regulation in relation to vapes, because we will have to go to further consultation to highlight the flavours and colours and so on that we're looking at.
And when we saw Professor Khan back in February, who's obviously, it's his mind's eye that a lot of these proposals came from the Khan review, and he said to us, talking about a licensing scheme for the sale of tobacco and vaping products that will be a national scheme run by local authorities. He said decisions on licences are made at the local level. Any concerns can be included within the licence. For example, not selling cigarettes close to a school or vapes to reduce the appeal. Local authorities can do that if there's a licensing scheme. Is it something the government might consider introducing maybe at later stages in the bill, or is the licensing scheme just being ruled out at this stage?
So the concern we've had about licensing is first of all, as I say, we are not trying to outlaw smoking for adults. We want to support them to quit. This is not about stopping people who can already smoke from doing so. We have, however, looked at the impact of that licensing policy, or the proposal, I should say, in New Zealand. Often I am challenged on the fact that New Zealand has stepped away from its own commitment for a smoke-free generation, and we believe and understand that one of the reasons for that was that New Zealand was looking to license retailers to sell cigarettes, and the figures I have been provided with were something like going from 6,000 vendors to around 600. We do not want to go down that route. We want to ensure that responsible retailers sell these products as they within the law as they have to today, let alone in 2 or 3 years' time. And so we do not have plans for that at the moment.
Yeah.
No.
Okay. No, well, that's perfectly clear answer. That concludes our session. 17 subjects we have covered in 90 minutes. Incredible, isn't it? It's so much to discuss, and we could do it for another 2 hours. But hey, that fun is held over till next time. Secretary of State, thank you so much. Permanent Secretary, thank you very much for your time and for being here today. Have a pleasant Easter, and we will see you next time.
Thank you very much indeed. Thank you.